A very good evening to everyone. We are glad to see your participation in our Global Diabetes Summit. Hope you all had a great learning session yesterday on the treatment guidelines. And in case you have missed out on this session, you can always go back and watch it in the DocLex's archives. Moving on, so an interactive session is planned today on the latest developments in the field of diabetes and its treatment. So listen to our key opinion leaders from the field of diabetology and endocrinology opine on some frequently asked questions. We hope we can always take away some insights from today's discussion as well. For today, we have leaders like Dr. Banshi Sabu, Dr. A.G. Unnikrishnan, and Dr. Hemant Thakur. Welcome to the panel, sir. We are also thankful to Dr. Kulin Shah for accepting our invitation to moderate today's session for the panelists. Dr. Kulin Shah, with over 21 years of experience, is a consultant diabetologist with special expertise in diet and nutrition counseling. Over to you, Dr. Shah.
Hello, friends. I'm Dr. Kulin Shah, consultant diabetologist practicing in Mumbai. 14 November is designated by IDF and WHO as the World Diabetes Day. It was created in 1991 to address the growing concerns over an alarming rise of diabetes cases all across the world. This day was selected as it is Sir Banting's birthday, who was one of the co-discoverers of insulin. According to IDF in 2019, approximately 463 million adults between the age of 20 to 79 years were living with diabetes, and this number is going to increase to 700 million by 2045. In India, approximately 77 million people have diabetes, and it's expected to increase to 134 million by 2040. So today's topic of discussion would be on metformin, newer OHAs, complications related to diabetic foot, hypoglycemia, and newer technologies for glycemic control. And for this discussion, we have three very eminent panelists from the field of diabetes and endocrinology. So the first panelist is Dr. A.G. Unnikrishnan. He's the CEO and the Chief of Endocrinology at the Chelaram Diabetes Institute, Pune. He's a former professor in Department of Endocrinology at Amrita Institute of Medical Sciences, Cochin. He's a co-author of the largest multi-center study of subjects with pancreatitis and pancreatic diabetes worldwide. He has more than 190 PubMed index publications, and he's also the former editor-in-chief and the former executive editor of the Indian journals, like the Journal of Thyroid Research and Practice and the Indian Journal of Endocrinology and Metabolism. He has multiple awards and research papers to his own credit. I welcome Dr. Unnikrishnan. Welcome to this discussion, sir. Okay, so our second panelist for the discussion is Dr. Banshi Sabu. He's the Chief Diabetologist and Chairman of Diabetes Care and Hormone Clinic at Ahmedabad. He's attached to Shelby Hospital and Jivraj Mehta Hospital, Ahmedabad as a consultant diabetologist. He's the Executive Secretary of Diabetes India and is now the President of the RSSBI. Founder of NGO named Diabetes Care India to create awareness about diabetes and its complications in India. He's advisory board member of JAPI, Journal of Diabetology, International Journal for Medicine and Public Health, Journal of Nutrition and Nutraceuticals, and Journal of Obesity and Metabolic Research. Welcome, sir, to the discussion.
Thank you.
And the third panelist for today's discussion is Dr. Hemant Thakur. He's a consulting physician and a cardiometabolic specialist, and he's a senior consultant at Jaslope, Breach Candy, and Reliance HN Hospitals. He's a director and head of the Department of Medicine at Bhatia Hospital, professor and DNB teacher in internal medicine at Jaslope Hospital from 2001 onwards. So I welcome you, sir, Dr. Hemant Thakur, and I welcome all of you to this discussion. And today we'll be starting the discussion. So today I'll be starting the discussion on metformin. I'll be the moderator for these panel discussion. And sir, my first question would be to Dr. Banshi Sabu. Since we all use metformin as a treatment, it has been there in our treatment armamentarium since 1960s, I suppose. So, do you think that it should remain the first-line therapy for treatment of type 2 diabetes?
So primarily, pathophysiology of type 2 diabetes is insulin resistance followed by beta cell failure. Yes, we know there are multiple other pathophysiological defects which are there in type 2 diabetes. So primarily when you are trying to treat a type 2 diabetic patients, first we should do with insulin sensitizer. Insulin sensitizers are few medications like metformin and glitazones, and exercise is one of the best insulin sensitizer. So I will still go with the metformin should be the first choice. Most of the international guidelines still believe that it should be the first choice to start with a patient with type 2 diabetes. Yes, if somebody is not tolerating the metformin, then we can think of alternative agents. In an established cardiovascular disease, a patient who is having already heart disease and detected diabetes, even before metformin, we should use the molecule which have more cardiac benefit. And that is what SGLT2 and GLP1 analog can be given in a patient even before metformin in a patient with established cardiovascular disease. And this is a consensus statement which is in 2019 by European Society of Cardiology, which is again endorsed by European Association of Study of Diabetes. But at present, with Indian guidelines, which is of RSSDI guideline, we believe that metformin should be considered as a first line of agent in type 2 diabetes patients.
What is your view, Dr. Unnikrishnan?
So I completely agree with Dr. Banshi that metformin should be the first-line drug therapy of type 2 diabetes. And of course, lifestyle modifications like diet and exercise are the number one treatments for diabetes, type 2 diabetes, if I may say so. But after that, I think metformin should be the number one. Of course, there are some newer guidelines suggesting other agents. But given the robust experience of clinical data and evidence and experience with metformin, I think it should continue to be the first-line treatment, pharmacological treatment of type 2 diabetes.
Dr. Hemant, what do you have to say about this?
So, metformin has traditionally and conventionally been and still is the first line of treatment for type 2 diabetes, which one should start for all patients. However, this throne on which we have placed metformin is now undergoing a slight change. What is happening is newer drugs are bringing in newer advantages, newer pleiotropic effects. And a time has come when a lot of people are saying, why not something else before metformin? Of course, if you look at ADA and if you look at EASD and most of the associations, they will still say that, like the Congress party, Gandhi comes first and the others come next. Metformin comes first and the others come next. But I'm quite sure that in a couple of years' time, in certain groups of patients, you might want to start another group of OHAs, either simultaneously with metformin or even before metformin. So it is not now watertight that you must try that. Remember, we have always said the therapy of diabetes has to be tailored according to the patient. And if the patient merits something else before metformin, I would not malign or even accuse the physician of not doing what he wanted to do.
So, and what would be the absolute contraindication for prescribing metformin?
So I think people who are hospitalized in the ICU with critical illness, people who are undergoing major surgeries, people who are sick, people who have got advanced cardiac failure, kidney failure, sepsis. These are the only few contraindications to metformin. Even in those settings, even in heart failure, there have now been studies supporting the use of metformin, and current guidelines suggest that you can safely use metformin up to an eGFR of 30 ml per minute. So even in chronic kidney disease, metformin is not a contraindication, except in the more severe stages of chronic kidney disease or end-stage kidney disease. Of course, if somebody has intolerance to metformin, dyspepsia, or GI intolerance to metformin, that's another contraindication for metformin. Would like to know Dr. Banshi Sabu's views also.
So I fully agree with all those conditions which Dr. Unni had talked about. Chronic liver disease also come in the same way. So the end is so any person who is sick or severely sick, whether it's a CKD, chronic heart failure, or a patient with who is in ICU, sick patient or intolerant patient, definitely, or even insulin deficient also. So sometimes patients who are misdiagnosed as a type 2 diabetes, but they are insulin deficient. They are severely insulin deficient diabetic patients, where you may not start these patients with metformin, or metformin may not be a choice of drug. That does not mean it is contraindicated. So there are two ways of writing that, whether it is indicated definitely for all type 2 diabetic patients, and it should not be given in the patients who are very sick.
Yes, thank you. But one question from my side, what I wanted to ask is, in patients with CKD, so since Dr. Unni has mentioned that you can safely give metformin till the eGFR of 30. So what dose would you recommend? I mean to say, when I've been seeing patients with CKD, the patients have a lot of insulin resistance. And metformin would be a wonderful drug to address this kind of a condition. But then how much of dose would be suitable for these kind of patients, at least up to an eGFR of 30?
So I think up to an eGFR of 45, you can continue the same dose of metformin. Now, between 45 to 30, you can half the dose of metformin. Below 30, it is better not to use metformin, either for initiation or for continuing, better not to use.
So I agree with the Dr. Unni that up to 45, we don't decrease the dose of metformin. Below 45, it should be decreased to half. Normally, we don't go more than 1000 milligram. That is sufficient, because more than 2 gram, normally we don't give to our Indian type 2 diabetic patients. And less than 30, I also agree with Unni that we may stop, and we should stop rather. But occasionally, or very occasionally, patient is, highly insulin resistant to whom you want to give. It should not be more than 500 milligram, 250 milligram twice daily. But you have to be very, very cautious. And at this forum, I would not like to recommend that it should be given. It is completely individual choice, and you can decide on your own. And you have to discuss with your patients, and continuously you have to be in touch with the patients also.
So the same cases when we have patients with COPDs and respiratory problems, when we are little skeptical, where the lung saturation might drop low. So in those conditions, what would be your take on using metformin?
So Kulin, again, it is like any sick condition, one should not use it. That is number one. Already Unni had talked about all CKD patients, all CRF patients. Now, if suppose somebody is having a patient with COPD or a severe bronchial asthma or severe lung disease or interstitial lung disease where the oxygen saturation is already low, or the patient with COVID hospitalized for the oxygen saturation is low, wherever you are worried of hypoxic condition, which can lead to lactic acidosis, it is better not to use it, or preferably you avoid it. But if in a condition where diabetologist wants to use, then he has to be very, very cautious, and at the same time, he has to monitor the patients more frequently.
So metformin as a therapy for weight loss. So can you please comment on that, Dr. Unnikrishnan?
So metformin is not a therapy for weight loss per se, though metformin is said to be, so-called weight friendly. So it's a weight friendly drug, but it's not a weight loss drug. But yes, some people with type 2 diabetes, when they are obese, when they are started with metformin, they may lose a modest amount of weight, say 1 kilo, 1.5 kilos. But it's certainly not a weight loss drug. But studies have shown, because metformin suppresses appetite, it reduces the glucose absorption, has many effects on metabolism. So yes, on the gut microbiota, metformin has effects. So because of that, there may be a very modest weight loss, but not really a weight loss drug. So I wouldn't use it for weight loss, but weight loss would be an added advantage in people with type 2 diabetes or other indications where metformin is prescribed.
Fully endorsing with Dr. Unni. It is not a weight losing medication. It should not be used as a weight loss medication or pill.
Dr. Hemant, would you like to add anything here?
So I will say that all metformin users have weight loss, or at least stability of weight. And even if a patient is not diabetic, like in PCOD, or if the patient is only obese and has probably a pre-diabetic syndrome, or has hyperinsulinism, or even here a time come where metformin will soon and is soon getting replaced by other agents which have more
those kind of patients, what would be the role of metformin?
So patient with hyperinsulinemia, you are talking of like with a PCOS condition or a patient with metabolic syndrome or maybe a person with pre-diabetes. Now, whether we can use metformin or not. Theoretically, yes, we can use it and we are using it also. Most of the clinicians, endocrinologists, diabetologists who are practicing or particularly PCOS or persons with metabolic syndrome, we do use. But if you see the approval for and I explain the patient that medical store person may ask and may tell that this is a medication why doctor had given to you. It is a medication which to be given to a diabetic patient. So we have to explain the patient why I am giving, what will be the role and how it can help you in a given situation. So that's very important. And we do use in our clinical practice. Yes, Unni, your comments on this.
So I completely agree with that view about metformin. No comments at all, and very beautifully explained.
Yeah, I've seen so many gynecologists, they're prescribing metformin to their PC.
But it has been used with some benefits in PCOS. And if you look at pre-diabetes, studies have shown that lifestyle modifications can reduce the progression of pre-diabetes to type 2 diabetes by 58%, whereas metformin can prevent the progression by 31%. So therefore, but lifestyle modifications are very difficult to start and maintain, but metformin is easy to take. But definitely that thinking has changed, and now patients also and doctors also more interested in lifestyle modifications increasingly. And therefore, I think metformin has very little, if any, role in pre-diabetes, and it should be diet, physical activity, and stress reduction, which should be at the core of preventing diabetes in patients with pre-diabetes.
Okay, thank you so much, Dr. Unnikrishnan. Now the discussion moves on to the oral hypoglycemic agents. So now we have so many newer oral hypoglycemic agents available today. So what would be the initial combined management for the treatment of diabetes, and in which category of patients would you prescribe?
Okay, so now studies have shown, there was a study called the Verify study, which showed that an initial combination of a DPP-4 inhibitor, like say vildagliptin and metformin together, can prevent the need for a treatment failure rate to a longer period of time than starting with one drug. So that was some evidence for an initial use of this combination. And as you know, hypoglycemia is not there. But if you see patients who have type 2 diabetes and who are at high risk of problems like atherosclerotic cardiovascular disease, or if they have atherosclerotic cardiovascular disease, or if they are at risk of heart failure, or if they have or at risk of diabetic kidney disease, they should be prescribed the group of drugs called SGLT2 inhibitors, or sodium glucose cotransporter 2 inhibitors, because that drug seems to have a beneficial effect. Now, there is another drug which can be used early. It's not an oral anti-diabetic drug. That's an injectable drug called Glp1, which can be injected in type 2 diabetes at high risk of atherosclerotic cardiovascular disease. But fortunately, we now have that peptide in the form of a pill coming up called oral GLP-1 or semaglutide, which will soon be available. So these are some of the agents which may be preferred if there is a vascular risk. So to summarize, the routine patients, metformin alone or metformin with the DPP-4, but high risk of cardiovascular, cardiac failure or renal disease, SGLT2 oral tablets, high risk of atherosclerotic cardiovascular disease, you could choose a GLP-1 receptor agonist, the injectable one, but the oral one is becoming available soon, and the evidence around that is also being built up as we talk.
I fully agree with Unni that verified data had shown that early and aggressive diabetes can be controlled, and with the patients who have with atherosclerotic cardiovascular disease, it is better to add the SGLT2. But in our clinical practice, suppose a patient had come with a HbA1c of around 8.2. I'm just giving you a hypothetical situation. And what is your target A1c which you want to achieve for that particular patient? That is what we try to do, whether I should add one drug or I should start with two drugs or I should start with patient with more drugs. I mean, the combination of therapy depends on multiple things. One is that what is my target achievement which I want this patient, because if I'm going to use a molecule which will not cause hypoglycemia, my target could be less than 6.5. It could be a young patient who is just detected diabetes, 40 years old or 42 years. I wanted to keep his HbA1c even less than 6 also. I mean, if I aggressively control. So with lifestyle modification, I may use them two medication also to start with, and then I may continue with only one medication. There's possibilities always there. You can start with a patient who is having established cardiovascular disease or multiple risk factor for heart disease, or where weight loss is my primary aim. So only metformin may be insufficient. I may be adding metformin and GLP1. I could be metformin with SGLT2. So, what is your aim of treating that particular patient or a person who is sitting in front of you? That will decide what combination or how aggressive you are for a person. Suppose I am seeing just now before, I was seeing a 77-year-old lady with 7.3 HbA1c. So I may just go with the metformin. Even I had not started her full dose of metformin because she should not become intolerant. We started with a lower dose, and probably maybe in coming weeks, I may escalate the therapy. So there are multiple parameters which are deciding your therapy, your aggressiveness, and your combination therapy.
Dr. Hemant, what do you have to say about this?
Depending on what the patient has, but by and large, if you have an HbA1c of more than 8.2, you know that monotherapy is not going to work. And you don't want to leave a bad diabetic legacy behind. You want to give quick answers, and you want to make sure that the patient reaches target early. So these patients who have begun with moderately bad diabetic control, 8.2 and above, I would begin with combination therapy.
So, Dr. Hemant, what are the latest classes of oral hypoglycemic agents used in diabetes management in developing countries?
So we know that SGLT2 inhibitors, gliptins, have all now come into the market, including the analogs of insulin. So these are the latest classes, and insulin analogs can be rapid acting and ultra long acting. So a lot of these classes, these two new OHAs and new analogs of insulin.
Dr. Sabu, when we have a patient who is intolerant to metformin, so out of all these new drugs which are available for diabetes management, which one would you prefer? Or which all medicines can be recommended when a patient is intolerant to metformin?
So, Kulin, one more important thing, sometimes patients are intolerant because they are started with very high dose of metformin. I had seen some of the patients started with 1 gram twice daily, and 1 gram twice daily patients may not tolerate. Normally, starting dose is 500 milligram twice daily, but some patients who are not tolerating even 500, you can always reduce, and there are few companies in India which are making even 250 also. If you go still in pharmacology book, it is written that metformin should be started with a lower dose, and slowly you escalate the dose to the optimum dose which is required. So that is one way of either initiating the dose at a lower dose, and then slowly you escalate the therapy with 250 milligram twice daily or 3 times daily, and then making it 500 milligram 3 times, and then you are making 1 gram BD. I mean, that depends on, or you are comfortable with 1500 milligram, or you are okay with that optimum dose is 1 gram for that particular patient. With 1 gram he is tolerating, and 2 gram he is not tolerating. So that possibility is also there. So metformin, now let us understand that this patient is not tolerating 500 milligram, and we call that metformin intolerance or metformin causing diarrhea or metformin GI intolerance. Then first and foremost thing the clinician should write on the what I do, in file on left side only, I write in a capital letter that this person is metformin intolerant. So the next doctor, even if the patient goes to another doctor, they should not get confused that why doctor is not written metformin, number one. He or she should not try again metformin. I may write also that what was the problem, why metformin was stopped, and why I am adding other drug is a first anti-diabetic agent. So whenever we are doing, which is not normally a guideline-based therapy, I normally make a comment or a note specifically writing on my letterpad that why I am doing this. So, a patient goes, because in India, it's not like that the same patient will continue to come to you. He may go to again his general practitioner. Again, he may be a rural patient, might be coming from a different part of country, and may go to again his consultant. So, that consultant should not confuse that why a doctor, X doctor has written so and so prescription. So there should be an explanation for that. So if metformin intolerant, then we can use other anti-diabetic agent as a first therapy. It could be gliptin, it could be SGLT2, or it could be even EGI also. But mostly gliptin and EGI will not be a choice if EGI, GI intolerant patient will be. I may go with SGLT2 if not contraindicated.
What is your take, Dr. Unni?
So I think there are two things. One, as Dr. Banshi said, start with a small dose and move up. Second is that you can always treat the intolerance if you wish, GI intolerance. Tell them to eat less spicy foods. You can use proton pump inhibitors or find out the cause for that. But the third thing is that sometimes intolerance may be due to other drugs the patient is taking. You could address that, like patient might be on aspirin. So you could look at that intolerance as well. If you are very convinced that this is a patient who has got metformin intolerance, like Dr. Banshi said, I write down that there is a proven intolerance. I usually, another thing I found to be effective is using the sustained release formulations of metformin, little better than using the immediate release formulation. So these are some of the things. Now, once patient is metformin intolerant, my first instinct is to use a DPP-4 inhibitor because it's a simple default choice. And of course, if the patient has cardiac, renal risk factors, then I may think of using an SGLT2 inhibitor. But otherwise, a DPP-4 would be a very default choice because you can maintain a similar kind of blood glucose levels without hypoglycemia and without weight gain, even with the DPP-4 inhibitor.
Dr. Hemant, would you like to add anything here?
Amongst the remaining package of OHAs, you can choose whatever you want, depending on what is the kind of gastric intolerance. Like I said, you cannot have an algorithmic approach. You have to tailor it to what the patient suffers from, what his other comorbidities are, and what his symptoms are emanating from metformin intolerance. But the whole host of OHAs available can be chosen.
So, Dr. Thakkar, what are the new hypoglycemic agents in question?
SGLT2 and GLP1 RAs. These are the only two which lose weight. Gliptins are weight neutral. Metformin, by and large, is also weight neutral. But these two latter ones are also favorable.
Today, when we're talking about new oral hypoglycemic agents now, and like pioglitazone is, basically forgotten. I mean to say, when there used to be a lot of promotion when it was launched, and then a lot of voice was made on that, and suddenly then, came out studies showing that it is causing fractures and then cancer and all those things. But now, again, the data is resurfacing that, again, it is a very good agent as far as insulin resistance is concerned. So when a patient is not, tolerating metformin, and if we want to use an insulin sensitizer, so what would be your take on using pioglitazone, Dr. Unni?
So pioglitazone continues to be a useful drug because pioglitazone is one of the few insulin sensitizers available for diabetes care. Other than metformin, it's probably the only one. And there has been some good evidence of glucose lowering and cardiovascular protection. The only problem is it has too many side effects. It causes weight gain, it worsens cardiac failure, there's a FDA alert on macular edema, there's a risk of fractures, there's a risk of the perceived I don't really believe that it increases bladder cancer. I don't really believe in that data. Nevertheless, the data is out there and there are medical legal implications of prescribing. So as a result, we treat diabetes so that we can prevent problems like cardiac failure and diabetic retinopathy. Now, here is a drug which can potentially increase the risk of cardiac failure. So I think because of that, the use of metformin has come, use of pioglitazone has come down. So maybe the use can be restricted to where no other drug would be effective. Maybe in young, relatively thin insulin resistant people whom you want to add a sensitizer, lean, young, insulin resistant people you add as a sensitizer, that's one area. But otherwise, I can't, and a low dose for a minimum duration of time, maybe 2 years, 3 years. So other than that, I'm not a big user of pioglitazone, but I really wish that this drug is studied further, if not for this drug, but at least to understand mechanisms that could be used to make PPR gamma agonists, which is a class of drugs, which are even better than the present group.
What is your take on this, Dr. Sabu?
So pioglitazone in our Indian patients, if I just say, we are thin fat Indians, we are highly insulin resistant, and we see our patients who are responding very well to the pioglitazone. One of the major issue which we have with pioglitazone is weight gain. Again, it is not the visceral, it is the subcutaneous fat which increases, but still it is a weight gaining property. I am using nowadays more with the using the SGLT2 in combination, because that almost, making the weight neutrality. So you are not worried of too much 3-4 kg here, gain 3-4 kg here, because many of our Indian patients who does not want to lose the weight also, they have 25, 26 BMI and they don't want to lose one side, and this, combination works very well, and along with the metformin. So if my 3-drug combination which I want to use for aggressively controlling a diabetic patient will be metformin, pioglitazone, and SGLT2. As Defronjo's hypothesis is that 4 drugs should be used in all patients, along with that GLP1 analog should be considered. But as Indian patients who are not tolerating more of GLP1, cost is a major issue and injectable. So other than that, 3 molecules I'm using very often for many of my patients for early and aggressive control. We don't have Indian data to show that how sustainable it is, for how long the patients will have not a problem, and how long the patients can achieve or keep their HbA1c less than 6.5. But that's a unlucky part, because we don't have the patient's continuous data coming to us, because our patient may not come to us regularly on follow-up and we may not have the data. But still, I feel that long-term data, because some of the patients during this COVID time, or they could not come, and now I'm seeing that after 2 years or 3 years, when we started them, still they are keeping their A1C very good control. So it's a powerful anti-diabetic drug. But yes, we are worried, particularly in the elderly patients and old patients, female particularly, patients to whom you are already worried that they may have underlying cardiovascular disease. It can lead to heart failure, or at least not heart failure, it can lead, but those patients who have LV dysfunction, it may precipitate the heart failure. So these are some of the issues which you are really worried. I normally also would like to give the pioglitazone to those patients who are coming to me regularly follow-up. So when I ask them, you should come to me regularly, because I am equally worried for their fundus problem also, because macular edema. And we in our center regularly doing for our patients fundus examination. I see sometimes doctors write it and they forget to stop it, and they are not monitoring these patients for macular edema. So that's a major challenge for that.
Okay. Regarding the newer drug SGLT2 inhibitors, so how effective are they in controlling the blood sugars, Dr. Sabu?
Kulin, are you telling still it is a newer drug? I think since last 5 years we are using, and once this had become,
but you don't have any other drug after that, so it's a new drug.
I mean, now at the cost of other drugs, now it is cheaper than even sulfonylurea in some of the molecules. I think now even the primary care physicians are using for all their patients. So it's no more newer drugs. But one thing which I will say, that first time an anti-diabetic agent which had come to show that it can decrease the cardiovascular mortality. See, 5 major clinical trials which had happened, and they changed the complete therapy for diabetes. Like UKPDS had told us that yes, diabetes is to be treated early and aggressive will reduce the complication. Then we could understand from the accord or trial that your intensive control after 15 years will not work. It has to be done from the day one. And then steno, from steno 2, it is not the diabetes only which is to be controlled. Other risk factors are to be controlled simultaneously if you want to prevent the particularly macrovascular complication. It is microvascular, okay, only if the glucose control is fine enough. And it is the EMPA reg had, explained us that it is how you are treating diabetes patient that is also very, very important. So in between, the rosiglitazone stoppage story is also there, that how the molecule can cause increase in CV mortality. And other side, the EMPA-REG outcome study had shown us that it is the molecule which can also decrease. Even somebody is having established cardiovascular disease, even somebody is having a disease of 10 or 15 years of diabetes. So this is the molecule, this is the class of molecule. And then other GLP-1 also had come with a cardiovascular outcome data, and all other SGLT2. So these are the molecules which are decreasing cardiovascular disease or mortality, particularly CVD and other MACE, particularly hospitalization for heart failure. And even now we have the heart renal endpoints also, they are benefiting. So these are the patients with established all these problems. Still it can retard the progression, or it can decrease the hospitalization for heart failure, or decreasing the cardiovascular death, or decreasing CVD. So I mean, these are the molecules which we should use more often in our clinical practice. And now I think we are using really a good amount of number of patients who are using SGLT2 inhibitor for primary prevention also, as well as for secondary prevention for hospitalization for heart failure.
Yes, Dr. Unnikrishnan, one thing what I would like to ask you in continuation with this question is, suppose now, since because of the SGLT2 inhibitors, like you have a lot of glucose in the urine, right? So then what would be the effect of these kind of an, more glucose in urine? So what would be the effect on the urinary bladder, or would there be any risk of any carcinoma later on, or what is it?
So while there have been some initial concerns of urinary tract and bladder carcinomas, none of the evidence now plays out to show that these drugs have got any effects on neoplasia, bladder neoplasia, or anything like that. So the main effect of glucosuria is that the glucose is a rich medium for infection. So fungal infections, bacterial infections, there is the rare chance of Fournier's gangrene, inguinal infections. But let me say that all these fears were there when SGLT2s first came to our prescribing armamentarium. Once we started using these drugs, and once we gained experience, as Dr. Banshi Sabu said, over the last 5 years, we've been more or less comfortable with the benefits of the drug, the organ protection of the drug, and with good personal hygiene, as well as good hydration, people can overcome a lot of problems with this drug. Having said that, this drug is not a good choice in people with recurrent urinary infections, with complicated UTIs, recurrent urogenital fungal infections. But I'd say that these are very, very rare situations. In clinical practice, this drug has the potential to benefit a large number of people, because this drug has moved from diabetes treatment to being about glucose control alone, to a focus on organ protection, on kidney protection and cardiovascular protection. And therefore, at some of the cardiology and nephrology meetings, they are so excited about the drug because they say this is a drug for the cardiologist, this is a drug for the nephrologist. Ultimately, it's a drug for the patient. And we as diabetologists, we are happy that this SGLT2 inhibitor, which came from the diabetes care segment, is now being even effective in some people who are at risk of kidney disease and heart failure, even without diabetes. And if other doctors take up this for the benefit of patients, we are happy and we are ready to discover newer molecules from our spectrum.
So probably before we prescribe, then it might be prescribed already by the cardiologist and the nephrologist.
No, but Kulin, I think it is a mistake if suppose a diabetologist has not prescribed a patient, a anti-diabetic agent properly, and particularly SGLT2 inhibitor, and
Yes.
patient is now landing in a cardiologist or he is going to the kidney specialist, and then he is prescribing. I think it is mistake of a physician, a mistake of diabetologist that he had not prescribed. So I mean that should not happen first and foremost. And I fully agree with Unni that we are more than happy that a diabetes molecule is now used by cardiologists and nephrologists, even in patients who are non-diabetic also.
Okay, that's very good. Now moving on to the newer agents like GLP-1 agonists. So now, although they are very expensive currently in our Indian setup, and many of the patients are not able to afford them, but then for apart from diabetes control, weight loss for indication for weight loss. So how effective are they? If suppose if we are contemplating their use as a weight loss therapy, Dr. Sabu.
So number one, the GLP-1 which is available in our country is primarily agent which is approved for as an anti-diabetic agents. We don't have the GLP-1 which is available to our country. We don't have 3 milligram. We don't have Saxenda which is approved for weight loss. Yes, off-label we do use. Now, Kulin, what you are saying that it is not affordable for many of our patients, which I agree. For many of them can't afford, but 20% of our patients are highly affording also. They can afford, but it is still the injectable therapy, which is also one of the reasons for that. Sometimes even they are affording, they are ready to take injectable after explaining the patients about the anti-diabetic and weight losing property of this molecule and the benefit as far as cardiovascular benefit which are concerned with that. The tolerance is also a problem, GI. Even you explain the patient, you reassure the patient that this is not probably a side effect, this is another effect. You will have fullness, you will not like to eat anything. All these are the good effect because otherwise you will be not losing the weight. And this is the actual benefit of this, how it is going to have the anti-diabetic part of it and how it is going to decrease your weight also. But still some of the patients will not agree to continue it for more than, some patients may continue it for a few weeks, some patients for a few months, and very few patients will be for a few years. So, I mean, continuity of using this GLP-1 analog is not just one reason that cost is a major challenge. It could be cost, it could be injectable, it could be the side effect profile also. And I think the third part is still it is not accepted by a physician class in a large group. So, sometimes a patient goes back to his physician or his general practitioner, then, he or she may tell also, not needed, why you are taking so costly drug. So there are so many other reasons also. But I believe that GLP-1 analog are real wonderful drugs. They are the one which is actually at a pathophysiology, if you see, they are taking care of multiple pathophysiological defects of type 2 diabetes. It is glucagon suppression, it is glucose sensitive insulin secretion from the pancreas. It also decreases the weight. So decreasing weight will decrease the insulin resistance also. So, everything is getting at the brain level also, its satiety will go down, the GI system. So that everywhere it is working and multiple pathophysiological defects are taken care. So why we are treating diabetes? Just not for the glucose control. Primarily, if you can treat a type 2 diabetes where you can treat pathophysiology also, definitely the chances of getting reversal will be high. Now, actually, reversal of diabetes means you give some patients a very low-calorie diet. But how many of our patients will continue to take that low-calorie diet? Now, if you initiate these patients on GLP-1, and then their calorie diet, their content of the diet, the calorie will be very, very significantly low. And after some period of time, you may stop one by one other medication, and probably after 6 months or 12 months, if patient is highly motivated and he can stop even his GLP-1 analog also, and now he's stopped from all the medication. So actually, in true sense, I am not doing reversal like what the direct trial is talking of, that you just give the patient on day one that you stop all anti-diabetic drugs and take the low calorie diet. Rather, I will go with one by one, that I will start the patients on GLP-1, motivate the patient, starting the patients on a low calorie diet, and slowly I will stop all these things. First, I will stop sulfonylurea insulin, hypoglycemic agent. Second, then I will stop the glitazones and SGLT2, and then I will stop even this metformin, and then last even GLP1 will also go away. So I mean that's what the patient maybe in another 3 or 6 months now he understood the importance of low calorie diet, that it can keep his sugar so controlled and no hypoglycemia, and still he is losing the weight. And 10, 15, 20% of the weight loss you are helping the patient by adding the GLP1. So the first 10% he is doing with them, and now continuously he is maintaining his diet for 1200 kilocalorie, because the direct trial was talking of 700 kilocalorie, which is also for first 3 months. It is a formula based diet, which is very, very difficult for someone to continue for 3 months. It is for 1 or 2 weeks, it is still okay, but for 3 months is real difficult. And then to reintroduce him a normal diet, which will also not more than 1000, which is again difficult. So I mean 1000, 1200 kilocalorie, if somebody can maintain with only metformin, I think it is almost like a reversal of diet. We cannot say reversal, but we can say some sort of a very good control on a metformin. So I will not use the word remission or reversal, because that means is you have to stop the medication. So GLP-1 per se, I like them very much. Now we are going to have oral GLP-1. So we are very excited that in India, we are going to have oral GLP-1. The oral GLP-1 same, which is going to come maybe after 1 year, it is going to come again in once in a week, injectable. The data of that is showing even as an anti-obesity agent also. So probably that will be introduced in our country with a higher strength with 2.4 as an anti-obesity agent. So we will be using the same molecule as an anti-diabetic, and with the slightly higher dose with the same like liraglutide with up to 1.8 is an anti-diabetic, and with 3 milligram it can be used once daily as an anti-obesity agent also. So the GLP-1 are very good anti-diabetic, and at the same time they can be used, but at present whatever molecule GLP-1 available in our country are not approved as an anti-obesity agent.
Okay, thank you. Dr. Unnikrishnan, to continue the same topic, can you please throw light on the oral GLP-1 analog, semaglutide?
So it's a very interesting molecule, because an injectable peptide for the first time is now available as an oral pill for treatment of type 2 diabetes. And of course, there is the added benefit of weight loss. Studies have shown that the effects of this drug are comparable to some of the injectable GLP-1s, and also comparable to or better than even the SGLT2s in terms of weight loss. The drug actually combines semaglutide, which is an injectable GLP-1, with something called SNAC, sodium N-acetyl compound, which acts as a decoy, because it gets attached to the GLP-1, and the SNAC helps it to squeeze through the gut mucosa into the blood, and therefore be available to treat diabetes. So very unique drug. The drug has to be taken very early in the morning with a full glass of water. At the same time every day, there will be some variability in its absorption. So it will take some time for the drug's levels to stabilize. Of course, it is started at 3 mg, and the dose is increased to 7 mg and sometimes 14 mg. And now even doses above 14 mg are in clinical trials for weight reduction, because the weight reduction of injectable semaglutide is 15% or 15 kilos. But the weight reduction with oral semaglutide is not so much. It may be about 4-5 kilos. So can doses more than 14 mg be used for obesity treatment as an oral pill? So that's something very exciting, which clinical trials are in progress. The problem is, because as the dose increases beyond 14 mg, it may not be that well tolerated. So that's why the research is going on. But I think 7 mg is a good dose for people. And I feel this drug, once it is available, it will be a good addition to our present group of drugs. Of course, cardiovascular outcome trials and other trials of this drug are in progress, but the preliminary data is very promising with this so-called GLP-1 peptide in a pill.
So probably it is going to be launched by early next year, January or something. That is what I am informed. Okay. What are your views on this, Dr. Hemant?
Well, if the patient is well controlled and he still needs to lose weight, despite you giving him whatever you're doing, if it's not an anti-diabetic agent which loses weight, and there are only two of them. One is GLP1 agonist, the other is SGLT2. Yes, you can try it.
How is hydroxychloroquine used in your practice, Dr. Unni?
So hydroxychloroquine, as you know, it was a drug for rheumatoid arthritis, and it was found to have glucose-lowering properties. And subsequently, there was a pivotal trial which was presented to the Indian regulator, and the Indian government has approved its use in type 2 diabetes as an adjunct therapy. So it can be used as an adjunct to oral drugs plus metformin plus another drug. It has reasonably good glucose-lowering efficacy. The problem is hydroxychloroquine for a very long period of time is known to cause retinopathy. And the retinopathy, in MBBS textbooks, we used to read about bullous maculopathy, but that's not only retinopathy in Asian Indians with hydroxychloroquine. Of course, rheumatologists have used it for years and they say that it doesn't have an effect. But type 2 diabetes, or diabetes as we know, is associated with retinopathy. And using it for a non-diabetic rheumatoid arthritis is not like using it for a diabetes. So people with active retinopathy, hydroxychloroquine should not be used. But people whom you think there is no other choice available and there is a need for an oral drug, it could be tried. Yes, it lowers the blood glucose levels. But remember, again, you need to monitor the retinopathy, the ophthalmology screening for retinopathy. And sometimes after a few years, you might need to stop it because you don't want to use it for a long period of time to reduce the cumulative dose. So yes, for a short period, for a selected group, during that window, it may be beneficial. But remember to have the retinopathy element in the back of your minds.
So what is the recommended dose?
So the dose is only 400 milligrams once a day. So that's the dose which is recommended. And that can be continued. And once you complete maybe 2 to 3 years of therapy, then I think it's worthwhile reconsidering it. Annual retinopathy testing is a must. Another problem you might see is hyperpigmentation. I haven't seen it, but annual retinopathy testing is a must. And if there are any suspicious retinal changes appearing, you should do what is called a spectral domain optical coherence tomography, which we do in our hospital. And then depending on that, you may need to stop the drug if required. So these are some of the considerations, but by and large, the drug is safe. And even the retinal toxicity is very rare, occurs at high doses after many years. So it can be used selectively to treat type 2 diabetes. Of course, the cardiovascular outcome trial would have been nice to have, but that's not going to be there because it's too expensive for a drug which is already off patent and available. And so that would have been nice to have, but it may never come through. So use it carefully, selectively.
What is your take, Dr. Sabu?
So I'm not a great fan of hydroxychloroquine, to be very frank. And I don't want to use it just as in one add-on drug as a third or fourth line, where somebody is not getting good control of diabetes after 3 and 4. I will go with the molecule which will be more predictable anti-hyperglycemic effect. That's number one. But I may use hydroxychloroquine with the patients who have other problems like related arthritis, like now post-chikungunya. See somebody who is coming with a diabetic patient who is coming to you and having an arthritis problem, and still the sugar is around 7.4 or 7.5, and you want to use this molecule as that it will be also effective as an anti-diabetic agent, and plus you want to give this as an anti-inflammatory agent. With the person with a other rheumatological manifestation of diabetes, you may use it, but otherwise I'm not a great fan of using the molecule in my clinical practice.
Okay, thank you. Dr. Hemant, what do you have to say about this?
Excellent drug. I have been responsible for doing the clinical trial for hydroxychloroquine in the country as a principal investigator. Safe drug, 200 BID, works well. It can be used. It's also now recognized by DCGI, and it can be used in renal friendly, it is liver friendly, and it can be used across the board, not a problem.
Dr. Thakkar, how have the outcomes of bromocriptine been in type 2 diabetes patients?
Well, we used to use bromocriptine, but they phased it out. When we were giving it, the results were slow, plus there were a lot of side effects. So I think it's been phased out even internationally. So then when you have better drugs, you don't want to try a drug which is discarded.
Yeah, so now we'll be discussing about complications of diabetic foot or diabetic foot ulcers. So, Dr. Sabu, can you please elaborate the risk factors? What are there for development of diabetic foot and diabetic foot ulcers, and how to prevent?
So one of the biggest risk factor for diabetic foot is diabetes itself. Why we call a diabetic patient is going to develop diabetic foot, because that's itself is a major risk factor. But yes, the person with a smoking, persons with a uncontrolled diabetes, longer duration of uncontrolled sugar, they all are the major risk factor for someone to have a diabetic foot problem. But I think it is the early detection of a problem can prevent them to have full-fledged problem of diabetic foot, which may lead to amputation also. And where what we are trying as an RSSDA president or whatever the organization for which we are working, we are trying to increase the awareness at the primary care physician. And I think diabetic foot is one problem which is really neglected. Why we need so many diabetic foot surgeons? Yes, there are not many, but still, why they are getting this? Because somebody is missing it when it was a very trivial problem. When the problem was very minimum at that point of time, somebody had not thought that this could become a major problem. That is the reason they developed the diabetic foot or full-fledged problem. So these are the problem which is, I can say, preventable, not 100%, but at least 95% of that can be prevented, and whatever the number of patients which we are seeing today can be significantly decreased if primary care physicians become more conscious about examining each and every diabetic patient who is coming to their clinic.
So, Dr. Unnikrishnan, suppose a patient comes to your clinic, and when you are talking about the foot care, what will you advise the patient?
Every diabetes person coming to our clinic or has, usually undergoes their annual checkup, and that has to undergo a preventive podiatry checkup. So a podiatrist sees the patient and also does what is called the sensory testing. The loss of protective sensation is checked. An ankle brachial Doppler is done to rule out peripheral vascular disease, and also a biotissuometry is done to rule out vibration perception threshold. So the assessment of neuropathy and vascularity is done, and the patient is told about simple tips to keep the foot healthy, choosing an appropriate footwear, having a comfortable, breathable footwear with a back strap, for example. And in advanced cases, it's important to do a foot scan to see the foot pressures. But I think general advice, good advice to the patient to take care of the foot, to prevent interdigital fungal infections which cause cracking of the skin, which are the focus of spread, to treat it, to guide them on trimming the nails, taking care of the callus, how to deal with the new footwear. Instead of wearing a new footwear or shoe immediately, it's important to step into those shoes on a gradual basis, and then to prevent shoe bite and need to not to walk barefoot outdoors and things like that, and of course to report if there's any problem. So these are some of the advices that have to be given annually, and foot examination is very important. Even if a preventive podiatrist is not available, at least a clinical assessment of the foot, very, very important in a diabetes care practice.
So when do you feel that a patient needs to be referred to a diabetic foot specialist?
So all cases need not be referred. Supposing there is intractable burning, tingling, positive neuropathy symptoms, the positive symptoms or negative symptoms like numbness, then the patient may be referred. If there is a missing pulse or a suspicion of blackening or gangrene, needs to be referred. Any small minor infection like cellulitis of the foot needs to be referred, and any deformity of the foot, because the beginning is a deformity, and that deformity predisposes to an ulcer. The deformity could be due to neuropathy. It could be advanced neuropathy, which damages the joints, called neuroarthropathy or Charcot's. So any deformity should be carefully looked for. So these are some of the criteria where you might like to refer the patient. But in most cases, there is a simple loss of protective sensation. Then, good advice and tips on healthcare to the patient may be good enough.
So, Dr. Sabu, how effective, to say how important it is to advise a diabetic foot pressure scan, and how would we be able to alleviate the pressures, if at all, if the pressures are high? Then would you?
So offloading is very important aspect of a person's having a diabetic foot problem or who is prone to develop. But I think a simple clinical examination, I will not put that all primary care physician or all consultant physician who are not dedicatedly doing the diabetic practice should have a photo scan in their clinic. A simple examination. People are forgetting not to do a clinical examination. Just person is sitting in front of you or opposite to you on an opposite table, and we are not examining and just writing. And sometimes when they develop the problem, at that time we are talking to them about the offloading. So just examine the foot. You can see where the callosity is there just by touching it. Simple palpation will tell you where the callosity is, where the extra pressure is going on. And with that, offloading can be done. Very simple offloading, which we can explain the patient. And by offloading, not only this callosity will go, but those patients who are, far more than callosity, they have other problems. They have ulcer. They have already ulcer, which can, a potential ulcer, callosity with potential ulcer, even that may also get healed. So, a offloading is real sutra for a diabetic neuropathic ulcer, which can be treated. And I think in each conference nowadays, Unni is doing, myself is doing, even so many CME meetings on online conferences, everywhere we had kept a diabetic foot workshop or a dedicated symposia where we were talking about the offloading, how it is to be done. So simple methods, how to examine the patients, the clinician examiner. Now, this year in RSSJ, we have created a diabetic foot task force, the foot task force. And what we have invited some of the experts in the field of diabetes foot. We asked them to give a talk on different topics of diabetes, foot particularly. And all those topics, all videos now we are putting on our website, on our RSSJ website. So anyone can listen them, and it will be like in a workshop form. So in their clinic, like suppose Unni is giving talk, simultaneously is examining the patient, showing that how it is to be examined, what are the things to be done. So one can listen, one can see, and he can use in his clinical practice also.
And that's very, very interesting. So how important is the footwear? To say, in India, do you think the footwear for diabetes foot, the diabetic foot, the footwear industry, has it evolved, or how is the progress?
So if you are asking me, one is that dedicated diabetic footwear requirement is very, very low. Those who have deformities, Charcot arthropathy, or a person's already having amputation, there they require a dedicated diabetic footwear. Otherwise, you require a preventive footwear. So the preventive footwear is what you should advise to diabetic patients or those who are at the risk of developing diabetic foot problem, like particularly when you want to do the offloading. So for offloading, you may not require a dedicated diabetic footwear, whatever the footwear where the person is wearing, but aesthetically, these, in market, whatever the footwear which are available to us, they are aesthetically very good. While those which we are asked them to make something for a tailor-made type of footwear, which will not be so good and person may not like to wear it so, comfortably every time. So that is the reason what I advise that, whatever the footwear which they are using, or what are the things which we can do, some modification can we do. So these are the something which I ask the patient to do it. But yes, with the persons with amputation or with one or two toe is already gone or a half toe and some problem is there, then we go for the dedicated footwear also. So the market industry for diabetic footwear is whether increasing or not. If you are asking some corporate or some big companies coming in the diabetic footwear, no. But we have in each major city, now almost all big city of our country, they have somewhere where you can have the diabetic footwear you can ask for and you can get it. It is slightly costly, but it's still available for us.
Your take on this, Dr. Unni?
So I think Dr. Banshi is right. He very precisely said the footwear should be therapeutic as well as aesthetic. So I think there is a need in India to have more therapeutic footwear, which is also aesthetic, because if the design is good and it is appropriate, then people are likely to use it. And if they use it more and more, they are likely to benefit from it. The second thing I want to make the point is that the footwear should do what the foot cannot do. So areas which are at high pressure, you have to decrease the pressure by an appropriate thickening of the sole. So an orthotist is very important, so it has to be customized. At the same time, I feel that a simple orthotist-driven footwear, many people may not want to wear just because of the aesthetic. Aesthetics is a big issue because it has to look good. So I think there is a huge potential in India for appropriate footwear, which is also aesthetic. And that's where I think, there may be a need for better footwear in India. But otherwise, I agree with Dr. Banshi. Every city, has its own orthotist, footwear teams. That's all available.
Yes. So now moving on, the main the portion of our diabetes management when we give medicine. So what we are worried is all about low blood sugars. So hypoglycemia is one of the very, very important side effect of diabetes therapy. So, sir, what are the etiological factors for the development of hypoglycemia, Dr. Unni?
So hypoglycemia is usually due to a mismatch between medication and the clinical status. So if somebody is on anti-diabetes medicines capable of pushing the sugar from high to normal, but also to low, then if that person forgets to eat or has vomiting or diarrhea or has severe exhaustion, that person becomes prone to hypoglycemia. Also, if that person is on an excessive dose of, say, sulfonylureas or insulin, again, there is a predisposition to hypoglycemia. Some people are especially prone to hypoglycemia. Elderly people with long-standing diabetes, diabetic neuropathy, which includes autonomic neuropathy, because hypoglycemia, when the blood glucose falls, we have a neuroendocrine mechanism to push up the blood glucose levels. Glucagon comes into play, adrenaline comes into play, cortisol comes into play, growth hormone comes into play. All these hormones prevent the blood sugar from going too low. But when these responses are blunted, hypoglycemia can occur. So these are some of the clinical situations where hypoglycemia can occur. But remember, hypoglycemia is not a side effect of anti-diabetes therapy. It's an excessive effect of the anti-diabetes therapy. And good education, awareness, appropriate medication can minimize the occurrence of hypoglycemia.
Sir, would you like to add, Dr. Sabu?
I fully agree with Unni. It is the education. I think many times while adding a hypoglycemic agent, particularly sulfonylurea and insulin, we forget to educate the patient. And that is one of the major reasons for them to develop hypoglycemia. So, I mean, hypoglycemia education should be done in each and every clinic whenever we are prescribing a patient, which can lead to, potentially it can lead to hypoglycemia, particularly when you are using sulfonylurea or insulin.
What are your views on this, Dr. Hemant?
Yeah, the first is over-prescription. If you're giving him too many drugs, if you haven't measured that he walks that much, or if you haven't measured that his lifestyle alteration is that much, and maybe in your compliance, you haven't told him that you're supposed to walk 30 to 35 or 40 minutes a day. You cannot one day walk 1 hour, 15 minutes, and then the sugar drops, and the other day walk nothing. So these are common sense factors. It's just like you can get hyperglycemia if the patient eats 3 desserts a day suddenly and then doesn't eat anything else after that. So hypoglycemia, first is your prescription, then is your lifestyle. And then you have to discuss with the patient and look for a common precipitating cause.
Dr. Thakkar, what causes hypoglycemic shock and how can we manage it?
So hypoglycemia, usually most patients are able to palpably realize They suffer it, so they know it. It comes to their mind and they go and have their sugars and chocolate. But it's in the elderly patients who are living alone, who are not very mobile, who have little cognitive impairment, cannot think too well. They cannot go and pick up the sweet or chocolate, and they suffer from hypoglycemic shock, and they need probably intravenous glucose along with other things.
So now moving on, we'll be talking more about the newer technologies for glycemic control. So we've all been using time in range devices for management of glycemic control. So Dr. Thakkar, can you please tell me what are the pros and cons of using this time in range devices?
Time in range devices, before we use that, we must make the whole country glucometer friendly. And once we make all the patients glucometer friendly, that's when you can think of ambulatory CGMs and things like that. But the pro is of course limitless. The con is patient then shouldn't get a false sense of security where he sees his sugar is 120 and then he says, okay, I'm going to have so much of alcohol, so many desserts, and then I'm now going to give so much insulin. So this is what will defeat the time in range. So time in range is an important modality of control which we need to impart first to our colleagues and people treating diabetes, and then of course to the patients.
Now we have the CGMS and the Librel, the flash glucose monitoring, which is available with us in India. So, sir, Dr. Sabu, what is your experience using both of them?
So, FGM or the continuous glucose monitoring, to be very frank, has changed my therapy. The way I talked about the empiric outcome, when I see now my prescription before 4 years or 5 years, before that I was not using so often, and now when I'm using it so often, I see that, the completely my therapy is changed. It is actually making me a precise diabetologist. My practice had become more of a precision medicine. Now we can have a individualized therapy which we can decide for the patients. Now we know that where the sugar is increasing, where the problem of diet, where the problem of medication, where the person is going to develop hypoglycemia, how we can prevent the hypoglycemia, and how we can achieve a tighter glycemic control. Even with the judicious use of sulfonylurea, also in my clinical practice, we are reducing the incidence of hypoglycemia very significantly. So I think continuous glucose monitoring is completely revolutionized the therapy. So one aspect of a diabetes treatment was only giving anti-diabetic agent, but I mean just blindly giving anti-diabetic agents and only measuring average glucose is not the right way of treating a diabetes, to be very frank. I mean, one side you are just giving an anti-diabetic medication, other side you are averagely you are measuring. You are not knowing what is happening every day, because it's a 24/7 your glucose is changing in your body. And how we can just decide that average glucose of a person if less than 7 is fine and the person will not. Primarily, CGM was designed and they were, trying to achieve a tighter glycemic control in a type 1 diabetic patient who is on multiple insulin therapy. And we want to achieve less than 7 because that's the only way by reducing the microvascular complication. And at the same time, person should not develop hypoglycemia, because hypoglycemia was the biggest limiting factor for them not to have a tighter glycemic control. So that was the primary reason for them to have a continuous glucose monitoring. But now talking about type 1, we all know they should be on it, and because they can't afford and many of the issues, so we don't want to go in detail of that. But CGM in our type 2 diabetic patients also revolutionized the therapy. Even now, for a pre-diabetic patients, if I just want to give him a diet, a person to whom, he should reduce his weight, his diet is causing the problem. He's having just 6.3 HbA1c, 6.1, and I want to make it 5.7 only with the diet control. I think it's a continuous glucose monitoring can explain the patient that how a simple one bhakri or one khakra in the morning breakfast and 2 idli in the morning breakfast can lead his sugar 200 milligram, which otherwise he is not understanding that, yes, sir, this bhakri or this thepla or this idli or this dosa I am eating since last 20 years. How it can increase my sugar and suddenly 200 milligram? So, this really very, very self-explanatory. It is very important educational tool, and it also helps our patients for motivation also. So, I mean, it motivates. And sometimes patient goes and they bring two more patients that, sir, inko bhi laga do na, So, they just wanted to know that, my problem is that they also have the similar type of issue. I am very happy with that. Yes.
Very true, very true. Dr. Unni, one thing what I would like to have your feedback is, now I've been using flash glucose monitoring for my patients, and what I have found that most of the times the flash glucose monitoring system, the Libre, it shows a lesser glucose reading. If you compare, I mean to say, if the patient is checking with the glucometer, and if you compare it with the Libre, it shows a lesser glucose reading. So what is your take on that?
So I think that, even now we are in the very early years of CGM. With technology, it is likely to get better and better and better. For example, the initial Libre Pro sensor used to detect more hypoglycemias, detect more lower sugar levels. Now the second generation Libre sensor, the next generation, has been quite better sensor than the other sensor. And the next generation is going to become better and better. For the present, I agree with you that though it tends to show a little lower readings, I think that this is also one of the benefits of a real-time CGM, because it will never miss a hypoglycemia. So it will never miss a hypoglycemia. It may overdiagnose hypoglycemia, but it will never miss a hypoglycemia. And the first principle of medicine is to do no harm. So from that point, I think it is very effective, and it's a tool. It's a tool that can only do its job. And our job is to interpret the patterns and the trends. In fact, I call it the moving selfie of blood glucose. If I take a selfie of myself now, I may be smiling. I may be also laughing. But if you take my 24-hour selfie, I may have different expressions on my face. Similarly, a patient just does a glucometer test. Mera blood sugar to 120 hai, theek hai, khane ke baad. But then you see, when the patient wears a CGM, the patient can see his or her entire spectrum throughout the day. Like Dr. Banshi said, after eating a khakra or a bhakri or an idli dosa, they can see their glucose increasing, and that's tremendously empowering. It's a tremendous patient educational tool, and we are able to explain to the patients what we have been treating for years. And from that perspective, I think I agree with Dr. Banshi that continuous glucose monitoring has completely redefined the way that we are managing diabetes. And of course, with time, you will see better and better, more uses of the technology.
Now, today in these COVID times, most of the patients would prefer to have online consultations or telemedicine. So, Dr. Can you please tell me how has telemedicine impacted the care of diabetic patients in developing countries?
Excellent. Telemedicine has helped because with chronic metabolic conditions like sugar, you don't need to see the patient every time. You can see the patient once in 3 months. But if you do his teleconsultation maybe once a month initially or once in 6 weeks, you can help him tweak his readings and egg him on for compliance, push him for lifestyle alterations. It is impacted positively.
Dr. Thakkar, what recommendations can you give to increase the use of continuous monitoring devices in developing countries?
No, so recommendations would be very clear that I cannot across the board say you must always do it. The treating physician knows when he wants to do it, because if he's having a yo-yo or if he's having a tough time getting his A1C right, when there is a mismatch between finger prick sugars and A1C, which is where time in range comes in. You may have a HbA1c of 7.9 or 7.2, but your fasting and post-lunch are not looking congruous. So then time in range is important. So in such patients, if you did a CGM, you would be able to point out the time in range, tweak his prescription, change his exercise habits, and give him lesser macro and microvascular complications.
Dr. Unnikrishnan, Dr. Banshi Sabu, and Dr. Hemant Thakkar for joining us and giving us their valuable time and their valuable inputs on these various topics for the discussion today. At the end of this discussion, I would like you to share the closing remarks for this discussion. Can you please enlighten us?
World Diabetes Day is coming on 14th of November. As Kulin was talking, that World Diabetes Day is primarily to increase the awareness. And I always tell from the RSSDI that on this World Diabetes Day, not only we have to increase the awareness, but I think advocacy for diabetes is also to be increased in our country. People are not understanding the importance of sugar. They just consider it's mild disease, and that's not true. It's not mild disease. We have done recently a campaign, Defeat Diabetes campaign, for 3 months across the country to make people aware about that sugar monitoring is very, very important, and it can create a lot of complications. Even in during this COVID time also we had seen, and I think probably in this COVID time people could understand the importance of sugar monitoring too, and keeping it in under tight control really helps them for better outcome for the persons who was having COVID. The second, after awareness, advocacy, I think it's our action plan. So across the country, we all clinicians, all physicians, all diabetologists, all endocrinologists, we are trying our level best to increase the awareness, to do multiple programs related to this, and more of an education program. So our primary aim is not just for detection camp or doing camps for the diabetic patient, but yes, 50% of a diabetic patient, they don't know they are diabetic, and that is the reason, one of the way by which we can detect them by doing a detection camp or camp program where we can know who are undiagnosed patients, but to whom we should do it above the age of 25 or above the age of 30 who are at the risk of developing diabetes. There is an Indian diabetes risk score also. But what is more important than that, that those who are found to have non-diabetic, but still they have higher risk of developing diabetes because their abdominal girth is more, they have strong family history. I think also our duty is to teach and educate them for prevention of diabetes. They are the one who can be prevented. They are otherwise at the risk of developing diabetes, but I think we can educate them. We can talk to them that how diabetes can be prevented. So now we are moving from diabetes prevention to diabetes reversal. So now everything we want to cover that, a better control, a better care for our diabetic patients, not to have complications, but at the same time, diabetes prevention, and for some of them, who can reverse diabetes reversal is also possible. With these words, I thank once again Docplexes and to my colleague Dr. Unnikrishnan and Dr. Kulin for inviting me and sharing the platform with me on this Docplexes platform. Thank you very much.
Dr. Unnikrishnan, your views, your closing remarks for this session?
I think 14th November is World Diabetes Day. And I often think that why do we have World Diabetes Day, World Obesity Day, so many days? But one of the important things is that that day brings a heightened focus on the disease. Yes, 14th November is World Diabetes Day. But by using that day to improve the awareness about diabetes means that it's not just about that day. It's not just about that week. It's not even about that month or the year. It's about making an impact in the entire lives of people with diabetes. And not just that, it's an opportunity to make an impact on an entire generation of people living with diabetes, because the rate at which diabetes is increasing, affecting younger people and resulting in diabetes-related complications means that it's a time to act. And therefore, on this World Diabetes Day, I urge all of us to improve the awareness of diabetes among our patients and how to take care of diabetes. And this, I hope, will translate into better diabetes care across the world and protect the people with diabetes living across the world and endow them with health and wellness. Good wishes to all of you listening out there, all people with diabetes, my colleague, Dr. Banshi Sabu, Dr. Kulin Shah, and also the entire team at Docplexes, wishing you a great day and great time ahead.
Dr. Hemant Thakkar, your views?
At the end, I would say thank you to my panelists for being with me on the panel and answering these questions. And I want to thank Docplexes for arranging this panel discussion for the benefit of all our colleagues and the diabetic caregivers. And it is nice that this forum has been able to emanate all the responses for the benefit of everyone else. So I would only say that I am not going to say the same tune that we are the capital or the second capital. I'm going to say that diabetes is India and India is diabetic. More and more people are diabetic at younger and younger ages. So my message is, if you can shrug off this inherited factor by beginning early, by eating selectively, by using your feet and your muscles more than your fingers for apps and for doing jobs, I think your lifestyle is most important. An alteration in lifestyle will delay the onset of diabetes in you, even if you have bad genes. And as we know that lifestyle alterations can even reverse or significantly delay the onset of diabetes. For Diabetic Day, I would say, if you are diabetic, don't lose heart. You can lead a normal life. Stay compliant with your prescription, with your doctor. Have faith in yourself. Diabetes is a way of life, and you will live as fully as your neighbor who's not diabetic, provided you persevere, you give your best, and you make sure that you are compliant with medication and everything else that is advised. Thank you.
Last but not the least, I would like to thank DocPlexus for organizing this kind of roundtable discussion. To all the viewers, I'd like to tell that DocPlexus is the fastest growing online medical community in India with over 380,000 doctors from 99 different specialities. DocPlexus provides a unique platform for the medical community to interact, share, and learn from each other, and also from their in-house subject matter experts 24/7. And recently, they have completed 8 glorious years in the industry. And congratulations to DocPlexus. And I would wish all the best for the future endeavors. And on the occasion of the World Diabetes Day, I would urge all our doctor community to please take out some time to do some interesting activities for our diabetic patients. We have to increase the awareness about diabetes care, diabetes management, and I would want that all of us should participate in making our the life of our diabetic patients better and to educate them in order to prevent complications in the future. Thank you so much. Thank you so much, everyone. Bye-bye. Take care.
Thank you so much, everyone, for making this roundtable discussion clinically enriching and a huge success. As always, you all were impressively well prepared and extremely professional in the way you all kept us at the height of our attentions for almost 2 hours. Plus, a big thank you to Dr. Shah. You have been phenomenal making the panelists all appear at their very best. To our audience, hope you liked today's session, and thank you for your loyal viewership and questions throughout the session. Stay tuned for our ACME talk for tomorrow at 5 p.m. on Trend Talks on Diabetes, Today and Beyond. And until we see you again, please take care and have a great evening ahead.